you could go out and get jobs that pay pretty much what you guys get paid almost anywhere. All you guys are smart, you work hard, you know how to work hard, you know how to show up on time. And in this country, if you do that, you can get a job. You probably get a job that even pays more than what you're making. But you will find it very, very difficult to do a job that matters as much as this one. And when you look at this little girl, Phoenix, you know, that's just one example. And you know, all of us that are in the clinic or in the operating room, every day we see real stories where patients come in, and if we do things right, and if we do things well, and if we dot the I's and if we cross the T's the way we all know we're supposed to, and then all of a sudden we can have this massive impact on society around us. And you know, you know, what is it that we want? You know, what is it? You know, my kids are two of them are in high school now, and you know, what do I want them to grow up and be and do? I want them to grow up and do a job where at the end of the day they've made the world a little bit better. For you know, you get up in the morning and you find the world in a particular place, and then you spend all day kind of running on the little gerbil wheel, doing your thing, and at the end of the day, you want to just feel as if you've left the world in a slightly better place. And I can't think of any job throughout all of medicine or all of society in general where you have as high of an impact factor as we do here, taking care of people's lives. It's an honor and it's a privilege. So what I'd like to tell you a story about today is a project that I've been involved in for quite some time. And it's really a cool story, and it has kind of a funny ending. Megan, do you know the ending? Okay. So it has kind of an ending that's fascinating. Right? But let's go on. So I personally am involved as a consultant to two of the companies that are the drivers of what we're going to talk about today. And my name is on the patents of a lot of this technology that we're going to talk about. So the story starts with this drug called Palu-Corcel. And what Palu-Corcel is, they're not really stem cells. They are umbilical cells, okay? And they're umbilical cells. It turns out that when you deal with stem cells, not the kind of stem cells that Dr. Holland uses, but when you deal with stem cells that come, embryonic stem cells that come from discarded embryos, there's a lot of ethical concerns about do you feel good about grinding up embryos and extracting stem cells, or do you not feel good about that? And big companies like J&J, they really don't want to become a lightning rod for that kind of ethical question. And there are really good arguments on both sides, and we don't want to touch that here today, that argument of embryonic stem cells. So let's see if there's another line of cells that might do a lot of the same things that stem cells will do that have no ethical concerns. And that's what these umbilical tissue cells are. So babies are born, and then the afterbirth comes out, and the afterbirth is connected to the baby with the umbilical cord, and all that stuff gets pitched in the trash at the end of a normal birth. It turns out that the umbilical cords have cells in them that actively secrete a super secret magical sauce of cytokines, okay, so growth factors, that are good for developing babies. Babies when they're in the uterus, they breathe in that fluid. Right? There is no air. Their lungs are actually filled with fluid. They collapse, and they breathe them in, and they eat that fluid, and those cytokines help infants to develop. And they don't divide, so they don't grow, these umbilical cells, but they have what's called trophic effects, beneficial effects that help tissues grow and develop. So there are all sorts of different eye diseases that are degenerative for one reason or another, and where eyes just don't do well and they wither away. And one of them is retinitis pigmentosa. So it's an inherited disease. And so what the folks at J&J did, is they did a phase 1 trial on 7 patients where they took a cannula and they injected this palucorcel under the retina. And these cells, they live under the retina, and they secrete their super secret sauce of cytokines, okay? And those cytokines help reverse some of the changes of the macular degeneration from the retinitis pigmentosa. So they did this to 7 patients. The cells were really well tolerated in everyone, so nobody got sick from the cells. No, there were no inflammatory reactions. 2 of the 7 patients, actually had an improvement in the visual function from no light perception to light perception, from light perception to hand motion, and they noticed it. So there was what they thought was a signal that was there. But the problem is that this way of injecting cells, especially in retinitis pigmentosa patients, this looks like a really nice, clean drawing, but fundamentally you got to poke a hole through the retina to get the cells under the retina, which is where the retinitis pigmentosa problem is. And when those cells, so when you pull this cannula out, there's a little hole left in the retina. And the little hole that's left in the retina, some of these cells will leak into the vitreous cavity. And those trophic effects, plus the inflammation from an operation, okay, resulted in a very impressive scarring response that caused a catastrophic retinal detachment in 2 of these 7 patients. So here we have a scenario where we've got these cells, we've identified them, we've purified them, we've got them on ice in a big freezer in Vermont, which is where the facility is that makes the palucorcel. And it looks like they might help patients with visual problems if we can avoid the 2 out of 7 chance of blinding. Okay. So that's kind of an interesting question. So retinitis pigmentosa is pretty rare, but dry age-related macular degeneration is not rare. Dry age-related macular degeneration happens in 1 of 3 Americans over the age of 65. And there is a variant of it that's actually pretty common called geographic atrophy that can cause significant visual loss. It's a withering away of the pigmented cells in the back of the eye. So even though they did their initial trial on retinitis pigmentosa, their target in their minds was always, hey, let's try this on dry macular degeneration patients. And you all may know that we treat wet macular degeneration with injections, and those of you that are in the retina clinic know that the injection burden is crushingly high. Realize that of all the patients with macular degeneration, wet macular degeneration represents 10% of them. The 90% that have the dry macular degeneration, other than taking some vitamins, there's no treatment. You give them vitamins and you tell them to stop taking that there's no treatment for it. So there's a huge unmet need for treating dry macular degeneration. So here they kind of continued this. They said, okay, we got to figure out a way to get these cells under the retina without poking a hole through the retina, by doing a vitrectomy. So they came up with this eye science cannula, where they made a hole in the sclera, and then they made a hole in the choroid, and then they put an endoscope in from the other side, and they snaked this cannula in the subretinal space all the way to the back of the eye, and then they injected the cells. And they did this to 33 patients. These surgeries took, on average, between 4 and 6 hours, required 2 retinal surgeons to be involved. Again, the cells were all well tolerated, okay? There were no immune responses, but there was a 15% chance of retinal detachment, because the retina, remember, the retina is really, really thin. The retina is, out here peripherally, it's 80 microns thick. That's less than 1/10 of 1 millimeter, and it has a tensile strength of wet tissue paper, single-ply wet tissue paper. If you take a plastic cannula, and even though you kind of aim it in the right direction, this cannula would stitch out through the retina and then back in and back out, and they had all sorts of issues and technical problems, and then they had another surgeon holding the endoscope, and it was just a huge dog show. And again, the problem was this 15% retinal detachment rate. But here's the interesting thing. Despite the fact that they caused retinal detachments, they weren't as bad in the phase 1 as they were in the phase 1 trial, there was, if you look at the response rate, okay, the eyes that got the cells tended to do better than the fellow eyes, and this is usually a pretty symmetric disease. So the eyes that got the cells, so we think there's a signal, right? Here's the visual acuity data. They started about the same, fellow eyes, okay, and the eyes that got the cells. And we think we saw a signal that lasted for at least a year. And that was kind of, you see the slope of this kind of becomes the same here. This is the natural rate of decline. So we think we saw a signal out to a year. So again, we've got a less bad way of doing the surgery, although it takes a lot longer, and there's 2 retinal surgeons that need to be involved. And there's possibly a clinical benefit. So if you look at the back wall of the eye, you've got the retina, which is this. Then there's this thin layer of retinal pigment epithelium that separates a connective tissue called Brooks membrane that separates the retina from the choroid. And then the choroid sits up against the back wall of the eye, which is the sclera. Now the sclera has the mechanical consistency of my leather belt. Okay, if the sclera is tough as nails. The choroid is the most perfused tissue in the body. It's got the highest blood flow of any tissue in the body in terms of blood flow per cubic millimeter. Okay, interesting little factoid. And what we know is we got to get these cells into this space between the retina, which is a direct outgrowth of the brain, and the choroid. And it has to be in the subretinal space. If you put it in the vitreous cavity, it causes problems. If you put it under the choroid, it doesn't have an effect because it gets washed out by the choroid. It has a lot of blood flow. You got to get the cells in here, okay? So, and you have to get it here without creating a hole in the retina, which is ultimately the cause of the retinal detachment. Now, this is a surgical question. And if you have a surgical question, who do you call? You call somebody, and especially if you have a surgical question that relates to maybe somebody using the endoscope, okay, who do you call? Well, you call somebody who does a lot of endoscopic vitreoretinal surgery, and so somehow they got a hold of me, okay? So what we did is we decided, as a team of engineers, and so I was an engineer before I went to medical school, we decided let's go ahead and take a look at re-engineering the entire surgery, okay? So obviously going, just poking a hole through the retina didn't work. The eye science cannula going between the retina and the choroid didn't work. And what we did is we brainstormed and we came up with 4 different new approaches to doing this surgery. The ab-externo approach was basically the same thing as we used in the in the second trial that I showed you, where we make a hole in the sclera, we make a hole in the cord, and we use a more carefully, specially engineered cannula and instrumentation and so on and so forth to get it to where it is. It's called the ab externo approach. Here you see the endoscope. So I was able to do this surgery myself without an assistant in about 2.5 hours. And you know, on pigs, I wasn't perforating the retina, but I'll tell you something, it's hard, okay? And it's not, just because I can do it, doesn't mean that it's a approach that can be brought to market, okay? Not everybody can do all the surgical maneuvers. If you watch me dance, I can't dance, right? I can do endoscopic retinal surgery, I can't dance. You know, if you watch me try to like shoot a basketball through a hoop, it's pathetic, okay? And what we need is a surgical procedure that can be done by a vast majority of retinal specialists with the skills that they already have. So option 2 was this thing called a tangential approach, where we kind of put this funny lens on the front of the eye. I mean, we drilled a hole in the sleeve of this lens that was at just the right angle. We had a needle at just the right bevel, and the idea was we were going to drive it through. We're going to penetrate the choroid, kind of instead of up here. We're going to penetrate the choroid more at the equator of the globe, where the retina is a little bit thicker, where we'll be able to see using this lens. We don't have to use the endoscope. Here you see a chandelier light source in there. To get into that subretinal space, advance the cannula and inject the cells. Okay. Then we did this thing called the suprachoroidal approach, where we penetrated the sclera where we can see it. We didn't penetrate the choroid, and we stayed with a big cannula in the suprachoroidal space, which is pretty easy to advance. And then we popped through the choroid at the very end to deliver the cells. And then what we did is we came up with okay, let's do the transvitreal approach is common. It's something that retinal surgeons do every day. We didn't want to abandon the transvitreal approach because that's the one that would be the most familiar to us. So we kind of came up with some instrumentation, little cannulas and a technique to do the transvitreal approach, where we would pop a hole through the retina a little bit more peripherally, inject some viscoelastic, and then slide a cannula through the viscoelastic bleb to the target area and inject the cell. So we then set up criteria, safety criteria, looking at retinal damage, perforations, detachments, choroidal safety criteria, did we create bleeds in the choroid? There were a couple of things that were absolute deal breakers, which were any cell leak into the vitreous that was defined as a never event. Then we looked at suprachoroidal cell leak, and then the capability, because these drugs, you know, the effect in the initial studies was only about a year. Okay, that's what we thought looking at the initial studies. So the patient has to be able to undergo this surgery once a year in order for it to be sustainable. Then we looked at another set of criteria for, you know, how complicated is it? Could we reproducibly get the drug where we wanted it to go? How hard was it to learn the surgery? And could the surgery be learned by a large percentage of your friendly neighborhood vitreoretinal surgeons with the skill sets that they already have developed? And then what about efficiency? So a 6-hour surgery requiring 2 retinal surgeons, which is what the previous version of this was, that's a non-starter, that's not viable. That represents an absolute barrier to entry that would prevent this from ever actually being adopted. How long was the surgery? Could we see? And then, okay, so in terms of efficiency, we all know that people's faces are different. Some people have really prominent eyes, some people have long eyes, some people have short eyes, some people have you know, big noses, small noses, big brows, and so on and so forth. And we need to be able to perform this surgery on the, you know, I'm looking at our room here, and all of you have very different faces, and operating your eyes, hopefully never, but operating your eyes would be different for each and every one of you, and that variability across gender, across races, across variabilities, and facial structure, and so on and so forth. So what we did is we did live pig surgery, okay, and we did hundreds of these. We didn't take the palliacore cell, that stuff is pretty precious, but we took the palliacore cell suspension, the stuff that the cells were in, we put some fluorescein into it, and we did hundreds and hundreds and hundreds, probably about 250 surgeries. Different pigs trying different permutations of these 4 systems. Here you see a transvitreal approach. Here's the special cannula we came up with. Here you see the cannula. This is the viscoelastic bleb. Okay, that's the optic nerve. And the cells are being injected here, but they're appearing here and they're leaking into the vitreous here. You can see it. So this was a fail. Okay. Yeah.
So the cells, when they leak into the vitreous, cause like super aggressive scar tissue?
Correct.
Okay.
That's why it was defined as a never event. But then we had one particular surgical approach where we just hit it out of the park every single time. So here you see subretinal bleb. This is what they're supposed to look like in pigs. And it is the suprachoroidal approach. Okay. So after we figured out that the suprachoroidal approach was the right way to do this, then we had to kind of mainstream the surgery. And what we did is we developed this system where we had a third arm that clamps to the wrist rest, and this gizmo that has 2 little tubing lines coming into the back of it, and a screw drive, and a little valve over here. And then we kind of set up the steps of this surgery that's never been done before, where we open the conjunctiva, we developed this little marker, a little template, we put in this little suture gizmo, put in made a sclerotomy, and then put the arm on, and then advanced the cannula into the suprachoroidal space, and then advanced the needle, and then we injected basal salt solution, and we said, is the retina perforated or is it not perforated? If it's perforated, then we don't turn the valve, or we don't inject the cells. If it's not perforated, we inject the cells. And we developed that and got the FDA to sign off on it. So there's this little syringe, it has the cells on it, and it's the suprachoroidal approach. So we slide the cannula, this white thing, between the choroid and the sclera, and then there's this little needle that drives out from under the choroid. It goes through the choroid into the subretinal space. And we did a phase 2B study that is on hold right now, but we did 21 patients. 2 of them we did here, 8 surgeons did it across the country. And it was called the Prelude trial. Okay? And because this was a new surgery that had never been done on human beings before, the FDA required us to basically do just 21 eyes as a phase 1 trial of the surgical approach before we could proceed with more patients to answer the question that at the time was the most important question, which is, does the palliacore cell work? Okay? So here, and then the plan was that after the 21 safety choroid eyes went through and did well for a year, that we would then enroll 210 patients and do the full phase 2 safety cohort. Answer the question of whether or not the palliacore cell effect that we saw in the phase 1B trial was real for patients with dry macular degeneration. So before we could go on to the phase 2B cohort, the FDA required us to demonstrate that this newfangled surgical procedure worked, okay? And that we could reliably get the cells where they needed to go with an acceptable safety profile. So what are the things that can go wrong with a surgery that you've never ever done on a human being before? That's nothing even remotely like anything that anyone has ever done to a human being before. Well, the obvious thing, endophthalmitis, that's a really bad thing, infection. Retinal detachments, significant hemorrhage, egress of cells into the vitreous cavity, which would have required a vitrectomy. Okay, that was defined as a never event, or the failure to deliver cells. And the FDA gave us these criteria that said, okay, what's an acceptable rate for a first-in-man safety study? Less than 1% endophthalmitis, less than 10% for everything else, and less than 20% of a failure to, maybe it just didn't work. So doing a little bit of statistics, they created these thresholds for these 5 entities. What's acceptable? Where do you say, ruh-roh, but keep going? And where do you say, ruh-roh, this is bad, and stop, and say that it doesn't work? So they created these safety criteria in conjunction with the FDA. So here we are. We did these 21 eyes, okay? And interesting, so everybody had their own, all the different surgeons had their own different tack on how to do it. So 15 of the 21 were done under local, but 6 of the 21 were done under general anesthesia. And the old timers like doing general anesthesia retinal surgery. Okay? The size of the geographic atrophy, the average visual acuity. This is in ETDRS letters. It's interesting. Most of the subjects were women. Okay, and obviously they were old because, well, age-related macular degeneration happens in people with age. So, I'll show you 2 of these videos. So this is what one of these surgeries looks like. On the left, you'll see kind of a diagram of what we're doing, and on the right, you'll see a live surgery. So we put 2 trocars in. We look at we put a chandelier in one. The second one is a kind of a safety trocar for us to put an infusion in quickly if we need to convert to vitrectomy. So here comes the light source. Then we open the conjunctiva. That's what that looks like. Here's this little suture stamp that we came up with. The funny thing is that little thing has its own patent, which I don't understand why, but okay. And then we make this little stitch. And the purpose of this stitch is twofold. Okay. It's twofold because what we do is we use it to pull the eye over, okay? And then we also use this here as a little suture tunnel, okay? To make sure that the angle of the cannula that you'll see in a minute is correct. And then we make a choroidotomy, okay? I'm sorry, a sclerotomy. We cut through the sclera, and this blue stuff is the choroid. So here's this fancy injector that we came up with. And once the sclerotomy is made, we take the cannula, we snake it under these 2 little suture gizmos, and that kind of holds it at the right angle. We slide it into the suprachoroidal space. We lift here, slide it between the sclera and the choroid. That is a relatively safe thing to do. Okay. Then we switch over to the Merlin, and we advance the cannula between the choroid and the sclera, and that's what this looks like over here. Okay. Then we advance the needle through the choroid, and you can see it tenting here a little bit. And in a minute, you'll see we inject a little bit of basal salt solution, BSS, creating a little bleb into which we advance the needle a little bit more. Then we flip the valve. There's a little bit of air in there that shows us that we flipped the valve. And then we inject the cell suspension. Okay? So here's the cell suspension going in. Here's the geographic atrophy. And the idea is that these cells will now help these eyes to see better. Okay? No, it's totally different. It's totally different. You dial it in, and then there's a manual injector. You have to inject slowly. Yeah, you inject over about 5 minutes. Yes?
How
It's determined by the FDA study design. So there's in theory 50,000 cells or 200,000 cells, and it's in a defined volume of 0.05 milliliters. No. So we got to figure out. That's a great question. What's the right dose of cells? Well, enough but not too much. And there's a whole way that when you're developing a new drug, the first thing you've got to figure out is there a signal? Do we think the drug works? And that's what the phase 1 and phase 2 trials are there for. And then you figure out in phase 3, okay, we see enough of an effect in the phase 1, phase 2 trials. And it looks like it's safe. We're not, creating all sorts of badness with this new drug. And after the phase 2 trial, we look at that data. The FDA and the drug company looks at that data and says, okay, so now let's rationally and sensibly figure out where do we think the data shows we're going to get the best treatment effect to side effect ratio. Okay? Everything we do has side effects. And we want to kind of hit that sweet spot. And that's what a phase 3 trial is all about. And we are way before a phase 3 trial. So here is, I'll show you another one of these videos because we have a little bit of time. This is one of the cases. This is the other case that we did here. Okay. This time without the diagram and full screen. So again, we're opening the conjunctiva, cauterized, get a nice bed. We look into the back and we see the geographic atrophy. Okay. We place the suture. And the reason why I'm harping on this surgical technique is because I think that medicine is going to see this surgical technique more commonly. Okay, we'll talk about that in just a bit. So here's the cannula going in. Okay, so when you edit video and you make things look fast, so these surgeries took make them about 45 minutes in our case. So here's the cannula coming in, and you'll see that I put my cannula a distance away from the geographic atrophy. Okay. And here's the BSS bleb that's forming. Okay, so now I'm like, I know I'm where I need to be. Then we flip the valve, inject the cells. The air bubble shows me, yes, indeed, the cells are coming through. Here's the cell solution. And the reason why I like this particular video is because not only did the case go really well, I think it only took us about 7 minutes to cannulate the subretinal space. And bear in mind that the design of this thing, it's not just any needle; it's the right needle in the right bevel. So here, post-op, 1 hour, you can see the cells sitting here. Okay. We took the patient upstairs and took some pictures. So here's the cells. That's the air bubble. And you'll see that the margin of the cells doesn't impact the center of vision. So here's what it looked like immediately afterwards on OCT. Excellent question. So the question here is, why would you put it right under the geographic atrophy? And hold that question because this story has a bunch of twists. So, excellent question. Right? Why don't you put it right under the retina? So it turns out that we did 21 eyes. We had no infections, okay? We had no retinal detachments. We had no hemorrhage. We had no incidences of penetrating the retina and having cells leak into the vitreous cavity. But we had 3 of the 21 where the surgeon just couldn't get it done, right? In one case, they couldn't even visualize the cannula. We still don't know what happened. That was in Boston, at a world-famous place. Then we had another one where they couldn't access, they could get the cannula, but they just couldn't penetrate the choroid. And then we had one where the surgeon thought he was in the subretinal space, but wasn't, and inadvertently injected suprachoroidally. And you would think that you would know that at the time of surgery, but you're doing this for the very first time on a live patient who might be awake. And you think you see something, you make a decision, and then on careful review of the video, it's like, oh, well, I wasn't right. It's no different than looking at an instant replay. Sometimes you see things on the instant replay that you don't see the first, live. So here were our results, okay? And the FDA was extremely happy with our results because, and just to kind of, we had nothing bad, and we had to fail 3 out of 21 times to get the cells where they needed to go, but didn't cause the patient any harm. In a first-in-human surgical procedure, and that is stunningly better than what was done in the previous 2 trials with the tiny core cell. So, to answer your question, very smart question. So where did the blebs end up? Well, there were right eyes and left eyes. This is where the blebs ended up. And you see that some of these blebs were very, very close to the area of geographic atrophy. Okay. So keep that in mind. Other adverse events really wasn't much. The most challenging step was penetrating the choroid, and we then subsequently redesigned the needle. We can do that a lot easier now. In 3 cases, there was some sort of confusion with priming the device and getting the device ready, so they had to do that. Again, at a world-famous institution, not here in Cincinnati. Our cases both were under 45 minutes, and which is fine. But what about vision? Okay. So with vision, so they started off at about 2160, and most subjects were stable at the 1-month visit. But 3 patients lost 15 lines of vision. And the reason why they lost, not 15 lines, 15 letters. 15 letters is 3 lines on the ETP, John. And some of these patients had pretty significant visual loss. And remember, the Hippocratic Oath is, first do no harm. And so why are these patients losing vision? Well, it turns out, here's a patient that lost vision, and then slowly started to regain it, and then regained almost to what they had over a year. But if you look at their geographic atrophy, okay, and you look at where the bleb was, okay, this is upside down from that. And you do something called microperimetry, which we did on all these patients. When patients lose their central foveal fixation, which many of these patients have, that's why their vision was so poor at baseline, they pick some other part of their macula, something that's not affected by the visual, by the geographic atrophy, as their preferred fixation locus, their preferred visualization. And in this patient, okay, the preferred retinal locus was about here. Here's the microperimetry result. And you have the cells sitting here spilling into, right under the area of this patient's vision where they were seen. So while it's entirely possible that these cells created their supersecret sauce and helped this area of geographic atrophy see better, okay, the cells were, so here's the preferred retinal locus is right there, okay, in this patient. This is what it was pre-op, okay, and here it is post-op. These are the cells, okay. Woohoo, we got them where they needed to be, but the surgeon in this case was a little too aggressive and got it too close. So, it's obvious that this retina isn't going to see real well because there's a hunk of cells between the underlying retinal pigment epithelium and the retinal photoreceptors. So that's why we don't, these are trophic cells. what we want is we want the stuff that they secrete. We don't want them right out of the cells. So, what we were able to conclude and present to the FDA is that the surgery itself was a ringing success. That the surgery itself was a ringing success. That we wanted to be careful not to inject directly under the retina. Okay? And that there were a few tweaks with the surgical, with the device and so on and so forth, that there was continued room for improvement. But if you've got 18 out of 21 successes and only 3 failures to deliver the cells without any surgical complications relating to the actual operation, that was 3 green, and they loved the surgery. So, and then we came up with these criteria of, all right, so what is the actual target of where we want the cells to be, and we came up with these criteria. So now the question, right, the question then became, all right, so what about the patients, the other, so you had 21 patients, 3 of which had visual loss, 3 of which didn't get the cells. What about the other 15? Okay. So the other 15, and I can't tell you what the data shows, but I can tell you that it looks like the drug itself is not going to move on to phase 2B trials. But that the surgery, okay, is going to be moved forward rather breathtakingly through partners with other drug manufacturers. So the really interesting thing, right, is that there are a ton of new sexy things, including real stem cells that could potentially differentiate into retinal tissue that could potentially get function, that you might potentially inject into the submacular space. Because we were able to get the cells into the submacular space when we wanted to, okay? Gene therapy, okay, and some of you probably already know that the Spark Therapeutic folks they just went to panel, and their results are superb. And we don't know what the FDA is going to say, but the first ever FDA-approved gene therapy for ocular disease is right around the corner, we think. Can't promise, don't know what the FDA is going to say. But we also know that the Cincinnati Eye Institute has been chosen as a center of excellence for gene therapy, one of a small handful of centers across the country. So we will be doing that here. And gene therapy needs to be delivered into the subretinal space. So that is a natural target. And I can't tell you whether or not that anybody is working together or not working together, but they are. It is natural to assume that they would be talking to each other, okay, the Spark folks and the J&J folks, and it is now. What I can tell you is that the surgery itself that we helped develop here is going to have a life of its own outside the Pau Corso project. So these are the surgeons that operated, and a procedure like this, yes?
How much of an improvement in vision is the FDA looking for this to, I mean, what is their end result goal?
So I think that so the answer is we don't know. It's a little bit, we don't know. But if you look at things that have been approved by the FDA in the past, does anybody here remember Visudyne? Okay, so Visudyne work like this, okay? Now, bear in mind, we laugh at Visudyne. I heard somebody laugh, okay? Yet, Visudyne was unbelievably better than anything else that had ever been there previously, okay? And because the options for wet macular degeneration prior to Visudyne were pretty lousy. And the odds were, if you got Visudyne, your vision improved 7% of the time. Your vision stayed stable 60% of the time. And it declined, whatever the balance of that was, 33% of the time. As opposed to a near 100% rate of visual decline, which is what happened if you didn't treat with Visudyne. If you left wet macular degeneration untreated. So the reason why they moved ahead with this is because that initial data that just shows that, hey, we can keep them from getting worse. Now, the difference between somebody who's 20/80 and stays at 20/80, as opposed to 20/80, 20/200, and then count fingers, is a huge difference in terms of quality of life. If you can keep somebody at 20/80, that's somebody that, with a simple magnifier, can read, can function. That's somebody who could get, potentially be a candidate for bioptic driving, okay? As opposed to count fingers, where, yeah, they can walk around and not run into walls. They have ambulatory vision, but the ability to read or write checks or really see any kind of detail is, you need to do low vision gymnastics in order to get those folks functional. So I hope that answers your question. So, I mean, I think just preventing or even slowing down visual loss, which is pretty relentless with expanding geographic atrophy in these dry macular degeneration patients, is a great first step. Do we want better? Of course we want better. And I can tell you that there are all sorts of other things that are in play, and that this surgery has a very high likelihood of playing a significant role in future next generation therapies that are right around the corner. So I can't give this talk without giving appropriate credit to my fellow surgeons that did the first in human trials, okay? The larger group of fellow surgeons, not all of whom operated, that were involved in guiding the development of this project. And then the massive team at J&J and Kaleidoscope of really bright engineers and design engineers that helped bring this to fruition. The price tag of just this surgery, in developing it and developing the device and the prototypes and all the trials and all the thinking that went into this is probably close. It's somewhere in the $50 to $100 million range, right? And that's before we hit any kind of regulatory burden. So I'm happy taking questions.
Dr.
Yeah.
How long does it take, what kind of time frame are you looking for, or how long does it take for the stem cells to differentiate?
So these aren't stem cells.
Right.
That's the whole point. So these are umbilical cells that don't differentiate. They're trophic. So they don't differentiate. They just sit there, they live, and they do exactly what they do in utero, and that is they secrete cytokines that are good for growing babies, and that it turns out we think are good for dry macular degeneration, except for at this point in time, they're not moving forward with the phase 2 trial.
After that, maybe some cell therapies?
So there are all sorts of different cell lines that are being bantered about by all sorts of startups. And so subretinal stem, so one of the things where this surgical technique is good is going to get repurposed, or may get repurposed, may get repurposed. You know, low-hanging fruit, gene therapy, we already talked about that. Low-hanging fruit, other cell lines, and there's dozens of them, okay? You know, there are cell lines that will differentiate into retinal pigment epithelial cells. At least that's what the phase 1 and phase 2A data show. But, you know, I can't tell you how often a drug will look great in phase 1 and look okay in phase 2 and then not make it into phase 3. Other things that are really interesting, my personal interest, because we're doing a little bit of work with methotrexate and nanoparticles. Okay, so you know, nanoparticles are all about sustained release drug. Well, there are drugs that we might want to target in a sustained release fashion, things like Avastin or Lucentis or Eylea, that if we put them in a sustained release model right next to the CNVM, okay, we just sit them there and they dribble out at a super, super low rate. We could give super low doses of these drugs, potentially avoid systemic side effects. There's this big thing of, are we causing strokes and heart attacks by, in our patients by injecting all these anti-VEGF drugs in the clinic? We don't think so, and the data, but the data is a little wishy-washy. Well, if we can reduce the dose by a factor of 100, but have the same efficacy by simply putting the drug right next to the CNVM, 5 microns from, or 20 microns or 100 microns from the CNVM, as opposed to just spritzing it into the vitreous cavity. And there's low-hanging fruit. So, and you know, the more you start to think about it, the more you think to yourself, oh yeah, now that we have a non-vitrectomizing, effective, safe way to access the subretinal space. And so, for those of you that have been in surgery with me, you know, I do all my surgeries heads up, okay? Everything is off the screen. You know, so here's a little, actually, here's my screensaver. So here I am operating, here's the microscope, and here's the screen. You'll see there are no oculars in front of me. I just looked at the screen. So the ability to, for example, take take the outside of the eye. We know what the inside of the eye looks like because we've taken a preoperative fundus photo. And then use the known relationships between the outside of the eye and the inside of the eye to then establish a digital template that you overlay onto your digital field, onto the live surgery field, that says, oh, okay, I want to target this particular spot. I want to avoid the vortex veins. I want to avoid the long posterior ciliaries. And I want to target this particular spot. In order to target that spot, I need to make my sclerotomy in this particular space with, you know, angled at 5 degrees or at 6 degrees or whatever, and have that template calculate just like you would for an intraoperative aberrometry, just like you would for intraoperative toric alignment, digital toric alignment stuff, just like you would for intraoperative templates for LRIs and that sort of a thing. Well, we're going to be able to do that for subretinal delivery. It's going to be really cool. So, there was a question over here. The preferred retinal locus. So the question was, how do you find the preferred retinal locus? So you ask the patient to find it for you, and you do that by there's 2 ways you can do it, but they're microperimetry. Okay, so you have the patient look straight ahead, and then you see where, you know, what little micro dots they use. So it's like a visual field, but honed down, and it's super specific just on the macula. The other thing you could do is you can shine a little target at the back of the eye, which is what the microperimetry device does, and we can say to the patient, Mrs. Grumbine, can you see the little light? Look at the little light, okay? And then they'll move their eye around, and you're imaging the back of the eye while they're moving their eye around, and you know, the little microperimetry aiming beam, okay, you see what they look at that with, and that shows it to you. And it, so for this study we did, but did we do it for How many of you do microperimetry on a regular basis on your patients? Okay. Nobody's, how many of you have actually done microperimetry on a single patient? Okay?
Would doing motility or ask them to look at our light and fixate on the light, for example, that would be.
No, microperimetry is different. I mean, you're imaging with an SLO, and you're seeing exactly where in the fovea they're seeing and they're not seeing. So, you know, it's not a mainstream sort of a thing to do, but it's something that you want to do if you're at the tip of the spear. Okay, so this stuff is tip of the spear, and it's exciting, and I'll tell you, it's an honor, privilege, pleasure, and a joy to be part of it. And we could not do that without the awesome team that we have here at the Institute. You guys, your impact factor is through the roof high, and I couldn't do this. You know, you can't. This is the kind of work you cannot do by yourself. You have to have a team of really dedicated people that can do that. So I'll stop talking because I think it's time for lunch.